basically we couldn't really do a whole lot, and in terms of procedures, we do conservative management. There'd be some surgeries, but nothing at the level that we can do now. And then maybe there'd be venography where they finally got contrast dye or iodine and could look at it under x-ray, but it was mostly for describing or pre-surgical planning. So I have a 16-month-old, and he's my third, and you know, you kind of start to feel like you got this thing figured out, but he actually hasn't been saying a whole lot, and you know, you start to worry, you're like, is he ever gonna talk? I don't know. And so here's a little video of him. This is his first word, and it kind of summarizes everything that I feel about all the advances that are happening, and also kind of shows the room to go.
Wow. Wow.
Says wow, and we're not really sure if he's using it appropriately, but you can tell that we overfeed him. So in a way, I think this is kind of his slow clap for, you know, our parenting, which is not great, but you know, my wow is real, is authentic for everything that everyone is accomplishing in this field, and I just feel lucky that I get to witness some of this. So moving into interventional procedures and everything that's happening, you know, I'm going to try and describe kind of some of the stuff you may have already heard of, talk a little bit about it, highlight some of the stuff maybe that's new to you, and then talk a little bit about the imaging, since I think I'm the only radiologist, and sometimes, you know, it's confusing, you know, what are these tests, or what are all these tests for? So we'll get into a little bit of that. So just to tell you, there really isn't, you know, there's still a role for surgery. Dr. Phlebectomy has managed to publish, even in retirement, this is from 2018, describing surgical intervention in colpotronitis. So pretty impressive. Surgery still plays a huge role, but there are other interventions that we can offer in spite of that. So what kind of symptoms? Our focus has mostly been symptom-driven over the years. And why is that? Because we don't want to make people worse, right? And we don't know what happens when we treat somebody who doesn't have symptoms, you know, and now they have a symptom as a result of our procedure. Do we really want to introduce a new complication into their life? So a lot of it has been symptom-driven. And at the end of this talk, I'll kind of touch on some things that are not symptom-driven, some of the things that we're leaning towards, you know, as more preventative measures. But in the meantime, we're focusing more on treating pain and bleeding, whether that's rectal bleeding, vaginal bleeding, urinary bleeding, or bleeding from an extremity, superficial thrombophlebitis, cellulitis, lymphedema, or swelling, and ulcers, and then DVT and PE, all the things that can accompany depending on the person. This is here, you know, as an example of skin breakdown happening because of venous insufficiency, or the vein just sitting in the blood vessels there. And then when we look at it under a venogram, X-rays in contrast in the veins, you can see there's just way too many of these veins, and it's hard to say, you know, which one of those would you treat to try and help this? We can't treat them all, unfortunately, and so that's part of the challenge in interventional radiology, is deciding where to go, when to go, if to go. So, and this can be all over. So here are some of the locations. Up here, these are MRI images of the legs, and you can see this right leg has more veins. There's a bright in it than the left leg. We're kind of backwards in radiology. And then over here, we have a pelvis person. If you imagine this is kind of standing up here, you can see there's all these extra veins in the perineum or the labia here, and it's really symptomatic for this person. They had a lot of pain, so we did some sclerotherapy on that, where we put a needle into the veins and treat it. Here's an example of venogram of an arm with too many veins there. And then here's another, or that's the MRI of that same person. So you start to see it everywhere, and each person presents with unique presentation and unique symptoms, so we have to really focus on that. This person had vaginal venous involvement here and ended up getting pregnant, and we helped her through her pregnancy in spite of all these veins there occupying the cervix and the vagina. And then this is just the coronal view, or kind of looking at it. Imagine if you were standing there. This person had rectal involvement. You can see all this bright stuff is the veins. It's kind of involving the posterior rectum there. And then here's bladder wall involvement. These actually aren't contrast. These bright spots are actually calcifications. So that person had veins, too many veins in the bladder wall that had calcified over time, some of them, and had hematuria, or blood in their urine. So these are just many of the different places that we can see this. What are our options? Sclerotherapy, this is a term that we use often to mean different things. That's where we inject a sclerosant or an irritant into the veins, and that can be alcohol, sodium tetradecyl sulfate, or sotradecol, bleomycin, polydophenol foam. And where you are kind of determines, where you are in the country, where you are in the world determines what they're using to inject these veins. For instance, polydophenol foam, we can't really get that in the United States very easily. Now we have it in the form of Varicosity, which is used for venous treatment in other places, but it's pretty expensive. It comes in a big jug that has to be used for multiple patients, so it's not as ideal. So we tend to use some other agents in the United States. You won't see too many people using polydophenol foam like Canada or other countries. Ambulatory phlebectomy, that's where we pull veins out through small incisions. Embolization, that's where we use a catheter to get into an artery or vein, and then we use little particles, beads, or glue to plug it up. Endoluminal thermal ablation, that's where we cook the inside of a vein using a laser or radio frequency. Image-guided ablation, and I'm going to touch more on that. There's a lot of exciting advancements coming out in MR imaging and using it to kind of nuke an area, if you will. So IVC filters, trying to catch clot that might form in the setting of treatment. And then surgical and dermatologic, which are not under my umbrella, but are still part of the whole picture. What kind of things am I thinking about when a patient comes in? Does the affected limb have a deep venous system? This makes a big difference, because if they don't, and you take out a bunch of veins, where's that drainage going to go now? Now they're going to have to create new highways back. Is it competent? Does it have working veins in it? When they stand up, does the blood fall back and disperse into the tissues, or does it get caught by the valves? So that's part of it. And then what is the extent of the varicosities or venous malformation in relation to the deep veins? Are there perforating veins, meaning connections there? Are there any persistent embryonic veins, whether it's a sciatic vein or a lateral marginal vein? What size are they? Because that's going to determine how we can treat them. If it's really, really large, it's going to be a lot harder to get a good burn with an endoluminal laser as opposed to some other techniques. So what procedures has the individual had previously, and what kind of complications might they have had? Is there DVT, superficial venous thrombosis? What's the size of the vena cava? Because if they do get clot and need a filter, they're only rated up to certain sizes. So these are all considerations. And then is there bony involvement, joint involvement? Because if we cause bleeding into a joint, that's not a good outcome. So, and then is there involvement of the visceral organs like I showed you earlier? Is the bladder involved? Is there abnormal vaginal bleeding? All of these things. So if somebody does get a clot and needs a blood thinner, let's say, we could worsen their bleeding if they're already having some bleeding. So the presence of the deep veins, that's a really important thing for us to consider. Here's an MRI, and here's the venogram on a person, and you can see this huge lateral marginal vein out laterally. Why it's called the lateral marginal vein. And if we put tourniquets or a little rubber band around the leg, then we can stop the flow through the superficial veins and see that there is flow in these deep veins. But we can't really see that if we just inject the superficial veins, because they'll preferentially go into the superficial veins. So these are some of the techniques we can use to see what somebody has and how it might be contributing to their symptoms. Ultrasound is really important because it allows us to see if there is insufficiency or incompetency of the veins. And then it also tells us, is there an artery that might be contributing? CT is really important because it can help show if there are phleboliths or those little calcifications, and then if other structures are involved. A lot of times, though, we end up using MR imaging, and this again is shows, you can see we did it in 3 pieces to piece together more veins in the left lower extremity that's involved and normal right lower extremity, and all the different things we look at here. And all of this helps us to know, where we should target our treatment and what else could be involved. Dynamic imaging has come a long way. So what does that mean? That's MRI, where they actually can look at it real time. They'll give you contrast, or sometimes not, with different techniques, and watch it go from the artery side to the vein side. So in this example here, you can see that before, here's the affected side over here, and this is the unaffected side. And the contrast is given to the patient, and before the artery even fills on the unaffected side, the veins are already filling on this side. So here come the regular arteries down, and this is already filled up. So that's dynamic imaging. What that means for the patient is you're going to be in the MRI scanner a lot longer because they're acquiring a ton of images. But it's helpful information. In this patient, it told us that there was an arteriovenous connection that was abnormal, and possibly multiple, and allows us to think, okay, we probably need to come from maybe the artery side instead of the vein side, or vice versa, depending on what you have. Sorry about that. So other advances, ultrasound contrast. Historically, we never had a contrast agent for ultrasound. This is something new, and here's a paper from Itkin at CHOP, and they're describing using it to identify that their needle is in a lymph node. We still have a long ways to go with lymphatics, and that's a really challenging area because they're so small. We can't really see them very well, but we're learning new ways to see them. And this is just an example of things we can use to help see the lymphatics or to image the lymphatics. So back to sclerotherapy and treatment. Here's a needle coming into a venous malformation here. And this, we typically use Sotradeco. However, bleomycin is really taking off in a lot of places. And the question isn't really can we, it's should we, and we're still waiting to see what are the results. Bleomycin is a chemotherapy agent historically used for lymphoma or testicular cancers, other things. But they've discovered that if you foam it up or mix it with albumin and inject it into veins that are abnormal and pool, that it actually can cause damage to the lining of the vein and cause them to go away. It doesn't cause as much swelling as other agents, and so people have really liked it in the head and neck, and also the arms or the hands and the feet, areas where you don't want a lot of swelling, because a lot of swelling in the head and neck can cause airway compromise. You can't breathe as well. And in the arms, it can cause a compartment syndrome or cause your nerves and vessels to be compressed by all the swelling. And so it's come into favor. However, we don't really know, is it actually as effective as some of our other agents? And that's a lot of the ongoing research is looking at the different agents and saying, which ones work? Which ones actually get rid of those veins or treat them? Which ones help? And so we're still waiting for some of that data to come out that's convincing enough. And there's a lot of controversy. Some people are all-out believers, and some people use it sparingly in certain situations. And there's really no algorithm yet that's let us know who are the best people to use this in. But it is being used quite a bit. The ISFA happened this year in May. It's the Vascular Anomalies meeting that happens every 2 years. And this was one of the abstracts presented there, 3,000 sclerotherapy treatments of vascular anomalies with intralesional bleomycin. So that's just an example of, this is a pretty hot topic right now. Bleomycin foam treatment. This was just published 3 years ago, looking at how it is a very promising agent with lots of potential. So this was also talked about at ISPA, or the meeting, the patient-reported outcomes, and Denise Adams talked about how important that is. Looking at what is the patient experience with this, and surprisingly in this, it says about half of patients indicate an improvement in overall health status following their sclerotherapy of bleomycin, particularly concerning pain and the severity of symptoms. However, most people only perceive little to moderate improvement in their health and desire further treatment. So we kind of have to weigh, what do we do with that? A lot of people said they had improvement, but they didn't really want any more. So that's one study that came out, and then there's another study comparing alcohol and bleomycin. And in this study, they said, alcohol is better at getting rid of the veins. However, there's more complications. Bleomycin wasn't as good at getting rid of the veins, but there were fewer complications. That's kind of a, gross summary of that paper. But these are some of the things that have come out very recently about this new drug, old drug that's been using in a new way. Embolization, this would be for your arteriovenous malformations, typically using a catheter inside the arteries, and then we can use glue, onyx. A lot of that hasn't changed too much, other than we're having a lower threshold to combine agents than ever before. So we might consider using alcohol and some glue, things like that. Image-guided ablation, and I have to credit my colleagues because I actually don't do MRI-guided ablation, but there is a very large growing practice at Mayo that uses image-guided for treating venous and vascular anomalies. It all started with kidneys, at least at Mayo, where if you have a tumor in the kidney, you can put probes into it and freeze them or cook them using different thermal technologies, and try and basically create a zone around the tumor, and then it dies. And it's a way to prevent having to go to surgery, and those tumors generally shrink up, and then they can follow them over time with imaging. They never have to have their kidney removed. They get to save part of their kidney. And so this is an example under ultrasound. There's this kidney tumor. They put a probe in, and then they cook it, and there's this dark circle there in the kidney. And then they CT'd it, and you can see these probes coming into the kidney here. And there's this zone around it. Well, somebody smarter than me said, well, we should use this for venous malformation, vascular anomalies, and see if that can help, because sclerotherapy sometimes helps and sometimes doesn't. So let's see if this helps. And so you can use ultrasound or CT, you can use MR, but we've typically been using MR lately, and that would be Dr. Woodrum, Dr. Navel here, and then Dr. Scott Thompson is our future fellow who's done a lot of the work as well with both of them. And so this was a case that was sclerotherapy in a foot, just as an example of a foot venous malformation. Here's the MR, where you kind of cut through the foot. Here's the heel. And all this bright is the veins in the foot. We stuffed needles in and treated it that way. Now with MR, they actually put those needles into the malformation, and then they put them in the MR, well, this all happens in the MR scanner, and then they end up using that freezing technology to create a zone. So instead of just treating the snake-like veins, you're treating the whole zone around the accumulation of veins. And it causes the endothelium, or the lining of the veins, to die. This is a paper produced at Mayo by that group describing this and describing that it's actually a feasible, safe, and effective second-line treatment. So people that failed sclerotherapy or failed other treatments went on to have this, and their pain was reduced. So in that, they described that both of these actually helped with pain management. And this is some of their images of the thermal or the laser ablation. So, for the effectiveness, they looked at 9 months, and they said, all right, is there complete pain relief? 13 out of 16 of them had it, and this was self-reported symptomatic pain relief and decreased pain medications needed. Obviously, it's small sample size, so there's a lot of room to go with that, but they also looked at what areas of the body. So they had 2 in the head, 7 in the extremity here, lower extremity, 3 in the upper extremity. 17 of those were slow flow venous malformations, which are also associated with KT and flows. So they looked at a whole group of those, and here's an example of one in the vastus intermedius muscle of the thigh. And you can see here beforehand is this group of veins, this bright stuff. And after they treated it that same day, it kind of has this dark appearance. And then 1 year later, you can see how much smaller it is there. So not completely gone, but it was treated and the pain decreased. So here's another example. This is one in the foot. This is a slice through the foot. You can see that whole group of veins there. This is really challenging area because there's so many tendons, so many nerves in that area. And here are the probes out of plane. There's 1, 2, 3 probes here. And they freeze that tissue. It creates what's called the ice ball. It's kind of like sci-fi, the ice ball there. And there's this black ice ball occupying the space of those veins. And this one's still waiting for follow-up. But on the immediate follow-up, 2 patients had a new paresthesia, so a little bit of nerve numbness and tingling after the procedure. This is out of 3 patients with foot venous malformations. One of those resolved after 2 to 3 months, and the other had not, which was, this is only out to about 6 to 9 months. Symptomatic relief, however, was achieved in all 3 patients with significant reduction in pain to levels allowing their desired activity, which was hiking, gymnastics, or working. So not a lot of patients yet, but it is exciting new technology coming out. We still see patients for preoperative treatment, so patients that this patient needed to go undergo a knee replacement, and they came to us for sclerotherapy before that, so the surgeon was a little bit more excited to replace the knee and not have to receive as much blood transfusion. We have requests from plastics before debulking, before amputation for ortho, and several other surgical indications where it's just they want to minimize blood loss, so we'll go do sclerotherapy or treat with any of these techniques. And then not just the extremities, we see this in the pelvis. Here's an example of venous malformation involving the pelvis with bleeding, and we treated that, and that improved quite a bit. So that's all kind of symptomatic treatment. Some people are switching over to doing things even without symptoms, so prevention. This is a paper by Mri at Boston who talked about, ablating the lateral marginal vein in toddlers and saying that this is feasible and low risk. And we're still waiting on longer-term data to come out, people to get older and see if it does help with that. But we can get into these small veins and treat them and hopefully spare them future problems. So that would be more the preventative side. From the arterial side, treating asymptomatic and incidentally discovered AVMs or arteriovenous malformations, things that we just happen to find here or there. And we say we should treat this because it's going to grow over the course of their life. We know that with arteries. Arteries are high flow, and they generally aren't going to grow as slow as veins. So in those situations, we've learned to pull the trigger a little sooner. And whether or not that's the right thing to do, is we're still waiting on time and looking at kind of patient outcomes, and all goes back to reporting your outcomes and helping with that, because that's where we grow and learn. So there's a lot of other therapies trying to solve similar problems. Clarabane, this is just a little device you put in the vein. It whisks around a little egg beater, damages the lining of the vein, and mixes it up with Sotradeco. The advantages of this, I haven't used it yet. It's only been used a couple of times here at Mayo because we're still kind of like, do we really need it? So everybody's always trying to come up with, a new solution sometimes to an old problem. And you'll find a lot of us go with what we have heard works before, but everybody has their own take on it. So those are just some of the things that you might hear about. Minimizing risk is always at the forefront of our minds. We don't want to give somebody that didn't have nerve damage before nerve damage, staying away from the nerves, watching for bleeding, preventing clots. We're looking at right now whether or not using anticoagulation or blood thinners after doing a procedure can prevent DVT and PE or pulmonary embolism. And then also looking to reduce skin breakdown, ulceration, and whether different agents work, whether early intervention is better than later, and the timing of all of it. So whether we can minimize risk by doing it when things are smaller as opposed to bigger. Moving forward, and this is my last slide here, the research we've been considering, sirolimus-eluting agents. There already are some out there, but whether there's some that might be a better application, looking at the genetic clinical correlations and trying to catch up with the medicine that's coming out. Collaboration, registries, meetings, working together in groups, because we all see a sample of patients, but none of us see everybody. And then patient-centered care, so tailoring the treatment, the medicines to the individual and making sure that we're providing the best care for the person and not treating people, like we would treat anyone. So subspecialization. Every day you're like, and you're the doctor of what? It seems like there's a doctor for everything now, but it really works to your benefit because people really care about their area that they're in. They start to learn everything about it, so making sure that you seek out those subspecialists too as part of, and that's the advantage of the multidisciplinary group. So here's a kind of working together here, one of our patients and her little friend wanted to be in the pictures for the chart. So it's kind of what we feel like, let us jump in there too, kind of go along with you, and thanks for letting us be involved in your